Colonoscopy, we know, is a camera-guided imaging of the lower intestine that aims to identify abnormalities. It is recommended for adults 50 years and older. The preferred repetition of this test is every 10 years as a routine procedure, and within 3 to 5 years if a polyp is found. A successful colonoscopy provides quality imaging of the colon with well-controlled sedation and short-term amnesia for the patient. Complications during colonoscopies are rare. The goals of this episode is to reduce complications such as bleeding, curb unnecessary pre-procedure office visits, reduce variation in expensive sedation techniques, and monitor effectiveness of additional procedures. Dr. Golden has just joined us now, so I will be glad to turn over this subject for him to finish discussing with you.
Good afternoon. We have a next slide which gives you kind of the patient journey. Patient will present. Now, to make it clear also, exclusions on this would not include people being admitted to the hospital, people are being examined for acute events like a bleed. This episode looks at diagnostic and elective procedures. The patient will usually present to a PCP or sometimes go directly to their gastroenterologist or their surgeon. The PCP will generally assess the patient and often refer for a procedure. Many of the procedures are now done, most of the procedures are done on an outpatient basis. Most of the referring units will take the referral from the PCP, have their office staff contact the patient, do a phone assessment about risk factors, and the patient comes in with information about a prep, and basically the next step is to be in the procedural unit the day of the procedure. Admissions after these procedures are rare because it's usually the same day recovery. Colonoscopy is performed, and follow-up for abnormal findings are usually given to the PCP or to the patient. We are looking, as we put this measure together, there are variations in performance and variations in what people do. So, and while we have always said in episodes that not every patient should get the same care, on average, people's care should look similar. And so if your average case looks different from everybody else's average case, then there's a difference in what they call practice variation as opposed to patient variation and individual patient decision-making. So in this case, and as we go through this, you will see that when we looked at this episode, there is variation. The vast majority of colonoscopists do not require a patient to be seen in the office prior to scheduling the procedure. Sometimes that is appropriate, but for the average screening procedure, it's usually an open access process, and the patient comes in the day of the procedure. There is not a charge for an office visit the day before the procedure. Some colonoscopists have follow-up visits, some don't. We also have practice variation in terms of the sedation techniques, and again, we have found that the use of propofol with an anesthesiologist or CRNA almost doubles the cost of the procedure, and we have found that while you don't necessarily say never use propofol, if you use propofol routinely, your cost profile and your practice variation will look very different than the vast majority of people doing the procedure in the state. So it's those kind of practice variations. You can get into location of the unit, whether it's an outpatient unit, an inpatient unit, the cost of those units. For Medicaid, that is less important than with the commercial payers, and we've seen in other episodes that facility costs can vary quite a bit and there are some very interesting conversations going on right now between, say, surgeons and hospitals about per-day costs and procedure costs, and people making decisions about locations and style of where the procedures are being done. We'll go to the next slide. So the episode design, as I mentioned, we had two community experienced gastroenterologists help design this and review the material. We also had a public workshop to go over this material, as well as a public hearing. The episode is triggered by an outpatient colonoscopy that is basically more of a screening approach. Complicated colonoscopies with significant major procedures are probably not included, though some snaring, biopsies, and so forth are included. Primary, secondary diagnosis, including conditions that require a colonoscopy, would also be involved. Acute bleeding or being done for emergencies would not be involved. So if you go to the patient exclusions, people who have been having the procedure in an ER or inside a hospital are not part of this episode. The episode time frame would be colonoscopies with or without additional procedures. The episode begins the day of the first visit to the PAP, which in this case would be the person or group that does the colonoscopy. So if the patient saw a primary care doctor who refers the patient, the primary care doctor is not part of the episode. If the patient comes in and then sees the GI group or the surgeon or whomever, that's when the flag starts. And then it also includes a post-operative period, usually within 30 days for complications related to it. Most complications occur within the first week to 10 days of the procedure. A lot of them are immediate. If there was, say, the rare episode of a colonic injury, bleed, though there have been some episodes where such bleeds or perforations are detected a couple of days later. But again, these happen in maybe 1 in 1,000, 1 in several hundred procedures. So it's pretty rare. Next slide. The design, the cost, the risk. We do have some risk factors to adjust the cost of the expected costs. So people's renal failure, diabetes. We've done regression analyses to make adjustments about that. Episode types, only providers with at least 5 episodes per year would be eligible for gain sharing or risk sharing, so you have to have a certain volume. We have quality metrics that include documentation of cecal intubation rates. Many of them are now being recorded automatically, but we certainly expect, I think the number was 75% in order to qualify for gain sharing. If you don't reach the cecum at least 75% of the time, that would not be considered an average performance that would qualify for gain sharing. As well, a documentation of the average time of withdrawal. There are numerous studies and standards that say, I think it has to be at least 6 minutes. Otherwise, if it's quicker than that, there's a chance you have missed things. You've gotten in there, but you haven't looked close enough for pathology. Quality metrics include your perforation rate, post-polypectomy biopsy rates, and bleeds. Again, fairly low. The biopsy rate is for reporting, but obviously high rates of biopsy can result in higher costs per episode. For those who are interested about do family practice doctors do colonoscopies, yes, if you're doing a colonoscopy and you're the PAP, you're in the mix. So that would be, you would be in the episode, and you would have to meet all the quality metrics and reporting requirements as well. For Medicaid, the PAP will be the person who performs the colonoscopy. So again, it doesn't matter your specialty, if you do the procedure, you're in the mix. And so that's because, in this case, the person doing the procedure is doing most of the decision-making, has most control over the outcomes, costs, etc. Next slide. Colonoscopy overview. Well, this is kind of a variation of what we've just talked about in the last couple slides. Again, when the PAP is first seen, the trigger is the procedure. You look backwards from the trigger. You then look forward for the complications, It includes preparatory visits, any special labs, diagnostic testing done in advance. So you do a lot of CBCs and INRs and so forth in low-risk populations that may not be needed. That would increase your cost per episode, professional claim rates. All of that would be involved with that. So we have ICD-9 codes, that will soon be ICD-10 codes. So you have any kind of codes for colonoscopies as your trigger, and then you have the pre-procedure window, again, more codes. This is technical stuff getting into the weeds. Happy to talk about it with your office manager, et cetera, if you want to get into the weeds. Our staff will be happy to chat with you about that. Patient exclusions, we kind of mentioned this a while ago. So significant comorbidities that would unfairly put you at risk. So pregnancy during the episode, that's an exclusion. People younger than 18, older than 64. Younger than 18 is a little unusual and not usually a screening procedure. People older than 64, most of the time that's going to be a Medicare procedure or dual eligible. If Medicare becomes involved, Medicare will probably have an episode that looks like this. They're not in this episode right now. These are only Medicaid patients and not dual eligibles. And then people who have inconsistent enrollment, people who have multiple insurers. So other private insurers may take this on, but if they have a primary insurance agent paying for most of the work, they're out of the Medicaid episode framework. And again, this is a follow-up of a variation with more details. Third column shows you some of the major complications, and that will eliminate you from the episode. So if you have ostomies, we're not going to include that. People who've had a laparoscopic surgical colostomy, organ transplants, people with severe chronic diseases, most of the time, kind of the obvious stuff. Yeah, people with inflammatory bowel disease are not included. That's not a screening procedure. People with ongoing severe cancers. We didn't include breast cancer because many of those patients are pretty stable. We didn't include things like chronic lymphocytic leukemia, pretty stable. So people who are actively getting chemotherapy, people who are really having an active cancer care. And again, we have a number of, we do this with all the episodes, perinatal, pregnancy-related conditions get you out of the episode. More codes that would exclude you from the procedure. Let's keep on going. And quality metrics, yes. Some of this would have to be put it into the portal. And these days, we expect folks to document whether or not they have hit the cecum. Most modern colonoscopy units actually have video recordings that can document and demonstrate that they've done that. That will soon, down the road, become a standard of care. Average withdrawal time, again, an expectation that of reporting. We expect that to be documented so that can be auditable if need be, but we expect people to report the percentage of their cases that meet these two metrics. We will also be monitoring follow-up billing codes for things like perforations and bleeds that come to the ER, the hospital, or have other outpatient visits.